presentation. This is yet another lecture presented by GUET ACM chapter and organized by Department of CSC GUET. We have had so far 4 online talks in last 4 weeks, and I think this is the 5th one. And the topic of this lecture is using agent-based model to fight the COVID-19 pandemic in Bangladesh. This is a very relevant talk, and the speaker is my good friend, Dr. Niaz Arifin. He's currently working as a simulation modeler and data scientist in the Silicon Valley, California, USA. You have probably read the flyer and learned already about the credentials of Dr. Arif. Some of the stuff that I will start with that is not mentioned in the flyer is Dr. Arif was the first stand person. He stood first in the HSC exam of 1998. We're the batch 1998. And then he got into the CSC department of GUET and then graduated in 2004 with flying colors. Then he went to University of Notre Dame to pursue his PhD studies. And even before that, he started quite a bit of publications in local and international conferences. I remember Arif working hard with another friend on some NLP research areas, even in the undergraduate years. And later on, I think he has changed field. He served as a research professor at the University of Notre Dame, as a postdoc in epidemiology and microbial diseases at Yale School of Public Health. As I mentioned, he has received his PhD from University of Notre Dame. His modeling research has been published in a book titled Spatial Agent-Based Simulation Modeling in Public Health. He has authored numerous journal articles. He has been designing and implementing an agent-based model for COVID-19 transmission and control in Bangladesh. He has actually been working as a part of National Data Analytics Task Force that is part of government of Bangladesh. Has been working closely with some of the officials of government of Bangladesh to model this disease and its spread and how to decide on policies on controlling it. And I also want to bring up that it has always been his intent that to make sure that this talk is a result of a team effort. It's not just Dr. Arifin, so I do want to call them out, the collaborators that Dr. Arifin has been working with very closely. It is a great pleasure for us that all of his collaborators have joined from different time zones, despite it being late night in some of those areas. Mr. Zafar Ahmed, he's a PhD candidate, State University of New York, Stony Brook, New York. Dr. Aisha Sania, research scientist, epidemiologist, Columbia University, USA, and Dr. Ruhul Amin Shatib, assistant professor, Fordham University, New York, USA. So with that, I will conclude my introduction and I will ask Dr. Arif to start his presentation. Thank you.
Thank you, Dr. Saifur Rahman, for the very generous introduction. I had no idea that you would go so far back, the way up to 98. Anyway, so you have already introduced my dear colleagues who have been working with us in this modeling effort. So before I start, I would just want to emphasize the multidisciplinary nature of our work. And for that, I would let them speak in a few words on their main area of research and work. So I would start with Jafar Ahmed, if you can please tell us what you have been working on in your PhD and also in your research.
Hello everyone, I'm Zafar Ahmed. I am a PhD student at Stony Brook University. My main research focus is high performance computing along with machine learning. For this COVID-19 project, I'm working on agent-based modeling, like supervised by definitely Arif Bhai, and along with the suggestion of Aisha Apu and Ruhul Amin Bhai. Thank you.
Thank you, Jafar. Aisha, please. Aisha, are you here?
Yes. So, hi everyone. So, as I said, I'm everything that I'm a physician and epidemiologist by training, and my field of research is actually quite different. I do research on early life exposure on child health outcomes, particularly on mortality, growth, and child development outcomes. And my interest in infectious diseases primarily when COVID started. And I think this work on ABM modeling is is an outcome of a friendship network. So I knew Arif for about maybe 18 years, right? And I knew the kind of work he does and how important it is for, could be for COVID situation in Bangladesh. And that's how the conversation started and the network grew.
Thank you, Aisha. Shaji, Dr. Ruhul, please.
Hello, everyone. Once again, thank you very much for the program. I'm Ruhul Amin. I'm a professor of data science at computer science department in the Fordham University right now. I finished my PhD last year in the summer, I work on quite a few things. I work on the sequence alignment algorithms. I also work on the natural language processing in Bengali, and now I'm basically working on data-driven approach on several development sectors. And currently during the COVID situation, I also started working on the this health sector. So one thing is that, like, you know, I've been working in Bangladesh for quite a few years right now. I'm founder of Piplika, and then I'm right now trying to infuse several data sources together to develop a surveillance system for Bangladesh. So, I'm very fortunate to work with Dr. Niaz Arifin in this project. I've learned quite a few things in agent-based modeling, which like I never worked before. And I've been very fortunate to be part of this whole group. Thank you.
Thank you, guys. So the goal was, the reason I introduced them is because for such a modeling effort where we are trying to tackle a pandemic of this complicated nature, you will need knowledge from different type of experts, not only computer science, not only epidemiology, but as the progress goes on, you will feel the need to bring in new experts from different domains. Okay, so let's start. So although Saiful mentioned the talk about, the title of the talk is about the COVID-19 pandemic, but I also included some of my early agent-based models. So I just have an alternate title on the top. So I call it Modeling Disease Transmission and Prevention using agent-based models. So we will have 5 sections. The section 1 has already been done. That was introducing our team members. And we'll start now with a very basic intro to agent-based models, and then we will give you examples for example of agent-based models for malaria, meningitis, and last but not least, COVID-19. So starting with agent-based models, I remember 3 or 4 years back when I was invited by Dr. Sohail Rahman, and I was standing right in the CSC lab giving a talk on agent-based models. And I asked this question with the first slide: how many of you are familiar with agent-based model? Please raise your hand. So I cannot see it now, but I hope some of you will at least find this interesting and challenging as well to tackle the pandemic. So in short, an agent-based model, we call it an ABM. It is a very specific class of computational models for simulating the actions and interactions of autonomous agents. Now, what do we mean by agents? Agents can be an individual, or like for example, a person, a car, a body cell. I'll give you some examples later on. That's why it's also called individual-based models. The history, it started in the 1970s with the first models came in, but at that time, computation was not so fast and not so cheap, so it didn't get very high popularity. But post 2000, with the fast computational resources, it became very popular. And nowadays, you will hardly find any science or engineering track where agent-based model is not used. The mathematician John Conway, his famous Game of Life, it is thought to be a predecessor of all modern ABMs. As you can see on the right, it's a lattice, it's a 2D structure of different nodes. You can think of these nodes as places like houses and other types of places where one individual can move from one node to another. So the 3 main components of an agent-based model are the agents, as I mentioned. It can be human, it can be a mosquito, It can be a body cell or a virus or a car or a drone. It depends on what type of thing you are trying to model. The next important thing is the environments in which the agents operate and move. For example, the house, the office, work location, or education facilities like school, college, or university, or even healthcare facility like hospital or clinic. Now, the third important component is the set of rules by which the agents interact with each other and also to their environment. This is very important because these rules, basically as computer scientists, we translate or code these rules into our agent-based modeling code. So the goal is to answer, for example, the primary questions of a model, like if it is a model of infectious disease or epidemic, then we will ask these sort of questions like, how will an individual get infected or maybe transmit the disease or even die due to the disease? And how will he possibly recover from the disease? How do we model human contact when we have millions of different agents? How do we model different interventions? Like, for example, COVID-19, we have lockdown and isolation. So these are the kind of questions that we try to model in the ABM by talking closely at each step with the domain expert. For example, if you are doing an epidemic model, then of course you need an epidemiologist, maybe a public health expert, and so on. On the right side in this figure, this is just a visualization software that I made to come up with different densities of houses and ponds that I use for my malaria model that I will give detail on after a couple of slides. Okay, moving forward. So why do we need agent-based models? There are so many other types of modeling paradigms. The primary reason is threefold. First of all, the heterogeneity. The name itself, agent-based model, means that you can have literally millions of agents, each differing on their age, location, even natural immunity or the disease capacity and those kind of things. So that will help you to answer this question, like who is the most vulnerable to get infected, why, and exactly when. The next important thing is emergence. So what we call it with a very famous equation, 1 + 1 is greater than 2. So this is incorrect, of course, but in agent-based world, this is true because when you look a system of humans, for example, like if you visualize it as a pyramid structure, then at the very bottom, we humans, we interact with each other. We do our work, we play, we eat, we sleep, we get and transmit disease. But these are all low-level actions. But if you look from a top level or an aggregated view, you will see that from these simple actions, there emerge some interactive things that are very helpful for gaining insights and very useful for policymakers. So this is what we call emergence. So one quick example is this, like if we know the rate of transmission and infection at a particular location, when is the best time or optimal time to adapt some interventions or extreme interventions like complete shutdown of Dhaka city and maybe a couple of other districts. The third important element is the natural environment for pandemic modeling. This is the reason, I'm sorry. So agent-based models are very flexible with GIS and other types of things, and it can model humans, COVID-19 virus, and other events like quarantine or ICUs, those kind of things. Now, another important point people ask is like, why not we use just simple SIR or dynamic models? The reason is, by definition, the SIR model, which is a susceptible, infectious, recovered, the compartmental model as it is called, it is very simplistic to model the relevant details that we need to come up with answers to important policy questions. And as such, it cannot capture the individual level diversity and heterogeneity. That's why we primarily use agent-based models. Okay, here are some quick examples from other domains of ABMs. For example, we have in biology, we can have models for cell growth or cancer treatment. In ecology, basically ecology is one of the earliest disciplines where ABMs were used. We have flocking and predator-prey models. In commerce, we have consumer behavior modeling, supply chain optimization. In technology, we have social network modeling. For example, in Facebook, millions or billions of users, you can model them with an agent-based model and try to see how we can answer some important social media type questions, like maybe targeting some specific group of users for promoting your campaign and so on. Then in networks, we have traffic congestion, drones, and autonomous cars. For example, Google and Tesla, they are building this huge army of cars. You can create an ABM to learn the best way to manage them. For disaster management, like epidemics or cyclones, of course, these are very good examples of ABM, and so on. So there are many more, and I'll refer you to another resource for that. So let's start with the malaria ABM. It is a well-known disease. For this model, I started this as part of my PhD work when I was at University of Notre Dame. And we developed different models for malaria for Kenya, Bangladesh, and Indonesia. So it is one of the earliest and deadliest infectious diseases in humans, with more than 1 million deaths per year. For Africa, the primary vector or the mosquito species that transmit malaria is Anopheles gambiae. And we have developed a biological core model that simulates the mosquito and humans as two different types of agents to understand the transmission of malaria and its control. Then we also developed a spatial extension by adding GIS on top of the model. And I'll give you examples on that. So this is what we call core model diagram of our malaria ABM. So what you can see here, this is the life cycle of a mosquito agent. So on the top, the blue things, those are aquatic habitats like ponds or lakes, or like let's say rivers, where mosquitoes are born as egg, and after a certain time, they go to the larva state, and then after a certain time, they go to the pupa state, and then they emerge as an adult mosquito. Now the adult comes to the human world as an immature adult. After a few days, they mate, and then the females are ready to bite humans for what we call a blood meal seeking state. And malaria is only transmitted through the biting of the mosquito, because then the organism, which is called Plasmodium, it is transmitted from the mosquito to the human. And if an infected human is again bitten by a mosquito, then the mosquito gets the Plasmodium, and then it transmits again. So this is how the disease itself transmits through the mosquito and the humans. And that's why the mosquitoes are called the vectors in this case, because they carry the disease. So moving forward, this is from a computer science perspective. If you look at the agent-based modeling code that we have developed, we have different hierarchies of agent and environment. On the left, I'm showing how we can actually do the inheritance hierarchy of a mosquito agent from an agent. And on the right, I'm showing different types of habitats, like aquatic habitats or human habitats, like where people live, from a more generic type of environment object. This might be of interest to CS people. Next, as I mentioned, we actually have used GIS with this type of ABM. So on the right, you can see the like 3 different zoomed map of Kenya. So in map 3, you see the whole Kenya. In map 2, you see one specific studied area that we selected. It is very close to Lake Victoria, and it is notorious for malaria infection. And from this, we zoomed in and identified different types of habitats, aquatic habitats and human houses, for modeling the disease. So moving forward, this is an example a classic example of applying different type of interventions. Because remember, the end goal of creating a model is to answer useful questions. Like we have different type of interventions available for any disease. Now, what would be the best possible combination of applying these interventions? Now, one might say, why don't you just go ahead and apply those? But the problem is, once you apply those, you have wasted your time and effort, and worse even, to blue, we are reducing the number of blood meals, that means the number of mosquitoes, and also the disease itself. So there were two important insights from this study. There was also a specific ABM that we developed for malaria for Bangladesh. And I am fortunate to have one of the important person in that paper, Dr. Mohammad Sohail Rahman, who is my sort of academic guru and my cadet college senior. So we developed this for Anopheles vagus. This is the dominant species for transmitting malaria in Bangladesh. And this was a good collaboration between BUET, ICDDRB, and University of Notre Dame. Going forward, this is a book that summarizes all of my malaria research. If you are interested, I can send you the link later. So now we come to the meningitis ABM, which is the second model I'm going to introduce you to. It was developed when I was at Yale University and developed for Niger, where we have this meningitis epidemics as a part of this sub-Saharan meningitis belt, which starts from Ethiopia in the east and goes all the way to Senegal and Gambia in the west. It is very unpredictable. It varies between January and May with tens of thousands of cases and substantial economic costs. There are 3 different serogroups, which are basically different species of the organism that transmit meningitis. And the serogroup A, which was also prevalent a couple of years back, is now eliminated. So we are left with three different serogroups which we need to deal with. In this model, we looked at the key characteristics of meningitis. We looked at the cost effectiveness study, for example, disability adjusted life year or DALY. But more importantly, we looked at the vaccination campaign strategies, and I'll detail that in a moment. This is the demography. So we had about 18 million people in Niger, which is the country in Central Africa in the belt. We had them stratified in 22 age groups, at 5-year interval, all the way up to 100. And we had different age-specific mortality in the model, and we had age-specific contact metrics. So this concept of contact metrics is very important. If you look at this figure, and each row and each columns denote one particular age group. So for example, if you look at this 5959, that will tell you that this red guy, it is about, let's say 20, around 20. So that means that in Niger, from last couple of years of data, we can say that school-going children between age 5 to 9 will come into contact of 20 other children in an average day. So this is a very good way to summarize human contact and mixing patterns and ready to use in an ABM. Next, I present the 2 other details. So on the right, you can see the 44 districts of Niger. So we had a little bit of GIS imposed on top of this model. And on the left, you see the straight line distances in a graphical way for the 44 districts of Niger. In this model, again, we modeled the whole Niger and each district separately, and also had the population movement between the districts. Now, the challenges, why we did this study, because there are 2 types of vaccine, the polysaccharide vaccines and the conjugate vaccines. The first type, the polysaccharide, they are only used in reactive campaigns, like for example, in a district, if the epidemic crossed a threshold, the government wants everybody to be vaccinated. And that's why it had only marginal benefit. The conjugate vaccine, on the other hand, is very effective. For example, the WHO already have MenAfriVac, which targets specifically serogroup A, and it already eliminated that particular serogroup from Burkina Faso, Mali, and Niger. But the problem is other serogroups like W and X are still there, still causing the epidemics. So that's why we need polyvalent vaccines, like different type of more effective vaccines, and in particular, the polyvalent polysaccharide and polyvalent conjugate, the PMP and PMC vaccines in short. So what we, and before proceeding with that, we also have another challenge. There is this possibility of strain replacement. So what that means is MenAfriVac, as I told, already targeted one serogroup, but there is a possibility that other serogroups will replace that and we will not get the benefit of eliminating serogroup A. So this is the worst case, and we denote it by CSR, complete strain replacement. And the best case scenario, of course, we can assume that we got rid of serogroup A and we will not be impacted by that anymore. So we call that no strain replacement. So moving forward, this is the life cycle of the meningitis model, where we start with the susceptible state. So an individual is susceptible, and if he or she gets infected, she goes to carrier. From carrier, she can go to either the disease path and then unfortunately die due to meningitis, or if he or she is lucky, he can recover and come to the immune state, what he or she could also reach directly from carrier if he did not get the disease. And then after losing the immunity, he can also move back to susceptible. This is called superinfection, where we allow one particular human being to be infected more than once. So the challenges were to have these different type of states properly modeled, and also the implementation of vaccination campaigns and the health and cost outcomes. So, but as I mentioned, the main question was what vaccination strategies will work best for Niger. So here we designed 4 different types of strategies for meningitis. One is BASE, which is basically using MenAfriVac and reactive. Remember, reactive campaigns are only done when a particular district passes a threshold. Like for example, in COVID-19, we are also thinking of reactive campaigns in the form of lockdown. The base prime will replace the PMC, they replace the MenAfriVac with more effective PMC vaccine, and attempts to contain local outbreaks within a particular district. And prevention 1 and 2 will target older age groups with PMC, and will try to reduce the risk at national level. Now, if you look at this table, you will see that these different rows, they operate with different age groups and with different types of immunization programs, like routine vaccination, where we just give the vaccine to the infants, or reactive, where we use different PMP or PMC vaccine for specific age groups, or preventive, where we can use some more aggressive vaccination strategy. So the question is, how much gain will we get if we, let's say, move from base to base prime, or base to prevention 1 or 2? That is the question we want to answer. We want to quantify it in terms of some good ballpark numbers, so that policymakers can take the right decision. So moving forward, these are some computational challenges that I faced. For example, the scaling problem. We have around 18 million people in Niger. If you imagine a Java program trying to simulate 18 million individual agents, it will need some huge amount of memory and computation power. Also, we needed to run it initially for 30 years, but then we needed 1 hour to simulate 14 consecutive years. So we had to cut down some of the years in that length. And the bigger challenge was calibration, because there are so many different parameters in this model. So if I can give you an example with this figure, you will see each of the blue sort of small bar here is the output from one simulation run with different random number seed. So why do we use different random number seed? Because we want to have variability in our outcome, and we want our result to be statistically significant when we do the statistical analysis on top of all the different replications. The black guys here, they are the real data. And as I mentioned, the red star here is the mean or the average of that variable, which in this case, in figure A, is the meningitis cases. In figure B, it is the prevalence, and so on. So you can have an idea here, like let's say it's a very high multi-dimensional optimization problem. If we have more than 30 different parameters here that we are trying to optimize at the same time, and with the help of different agents, like 18 million different individuals moving in the landscape. So moving forward, here is the key result. Of course, this is not surprising. If you can see on the figure, this is the % reduction in annual cases. What this means is how much reduction in cases we will have if we move from that base strategy of vaccination to base prime or prevention 1 or prevention 2. So if you remember the table I showed earlier, prevention 2 was the most aggressive and more expensive. That's why you would expect more gain in terms of disease reduction, and that's what we see here. So the bars here, they represent the 95% interval, but this is the scale of 0 to 100. So you can see if you apply prevention 2 on Niger, then you can expect around 80% case reduction. What that means is if you have, let's say, 1,000 cases today, and then you apply prevention 2, then maybe after a few years, you will see 80% cases reduced and you will only left with 200 cases. So that's a good outcome. And also, if you look at the other magnitudes for less aggressive strategies, they gradually decrease. So this is sort of a validated result of what we would expect from such kind of modeling effort. Here is another example of the result. So if you look at the annual number of cases over this 30-year simulation period, and then find the best 200 of these 2 million simulations, how does it look? How will you see the number of cases? So again, not surprisingly, for the base case, for 2 different strain scenarios, we have highest cases in the base program or the base vaccination strategy, and that gradually gets reduced as you apply more and more effective vaccination programs. So I think that was the gist of it. And with that, I would move to our last example of agent-based model, which is of course of interest now, COVID-19. And I would start with a very brief introduction and then move forward. So this right diagram, this is the life cycle of COVID-19 human agent. So we all are susceptible. We can get infected and be carrier. And it is very similar to meningitis because the disease transmission paths are very similar, but the parameters are very, very different. So from carrier, we can either go to COVID-19, which is the disease state, and unfortunately, some of us die, but those who are fortunate will recover and go to the recovered state, and after losing carries, they stay in the recovered state. Note that we do not have the connection from the recovered to the susceptible state because we are not allowing superinfection here. And this has been designed to model the transmission and control of COVID-19 in Bangladesh with important dynamics included like infection, transmission, and death. And we have been using this to test a variety of hypotheses and a variety of different interventions. And we have been using this to forecast the number of COVID-19 cases and deaths. So with this, from the next slide, I will hand it over to Jafar Ahmed, who has been tremendous in calibrating the model and moving forward with some of the important tasks. Jafar.
Thanks a lot, Arifin. First of all, many thanks for explaining the overall model with nice examples, and also for introducing the COVID-19 for agent-based modeling. So here, as you all are looking at the cycle of COVID-19, first of all, I would start my discussion with a question like, what is the goal of a modeler? So the goal of a modeler would be to somehow getting proved wrong. So let's say, the reason I say, so our goal is to, we will show some forecast to our policymaker, and what they will do based on that forecast, they will try to impose some prevention mechanism or some interventions which will improve the overall situation so that the pandemic flattens, right? So if you think in terms of the projection, one can do like with the agent-based model, I can give a single line where I can say, okay, from this point, from today, what will happen in next 15 days, or what will happen like in next 2 months. I can just give some single numbers, but it doesn't mean anything if I don't show what will happen if you add some intervention techniques. When we think about some intervention, the first thing comes to our mind is adding the lockdown, which we saw in our country, like closing all school colleges and like closing the work location and also preventing people from moving one place to another. But this is not that easy. We've seen in Bangladesh that it's not been easy, and people are not obeying the rules. There are different reasons. We are not going into the fact, but the point is that it's not easy to impose 100% lockdown. So what we should do, we should also impose some other intervention mechanism. The second intervention comes immediately to our mind is isolating the positive cases. Once you are tested, so we should isolate the cases so that it cannot transmit the disease to others. And there are some other interventions such as social distancing, travel restriction, and restriction in religious gatherings, such as like we will have our Eid al-Adha in few days. So what will happen if people goes to buy like kettles and all this stuff. So these are different types of intervention, but in this presentation, I will focus on mainly two intervention, the lockdown and case isolation. And we have mechanism to add other intervention as well. But let's see what happens with different type, I mean, with different varying levels of lockdown and case isolation intervention. Yeah. So first of all, I want to give a disclaimer. Due to some non-disclosure agreement with our government, we cannot show the actual numbers here. So if you see the y-axis, we don't have any numbers in y-axis, and we are not showing any number even at the right. So basically, I want to show the trend. Even without number, this trend means a lot, and we can see what's happening with different types of intervention. Here, for each day, each of this curve represents the number of infections that can happen each day under different intervention. So, like the first, there we can see there are 4 pictures, and the first one is under complete lockdown, which is the ideal scenario. If we can put complete lockdown in Dhaka city, and if we can have like 100% isolation coverage, that will be the blue line, which is kind of looks flat, but actually it looks flat due to the red line, which is 0% isolation coverage. So in each of these plots, you will see there are 5 lines. So 5 line represents different stages of isolation coverage. Like it can be 0% isolation where we are testing some patient, but we are not able to isolate the cases. Maybe we don't have enough hospital beds, so we don't have that quarantine mechanism. So the red line represents the 0% isolation coverage. The yellow line represents the 25% isolation coverage, where let's say if we have 4 people tested positive, we will just isolate 1 out of 4 people. So, and so on. Now, if you look at in here in the first plot, where if we can have a complete lockdown, you will see that compared to blue line, the red line is not exponential. The growth is kind of polynomial, and it's kind of manageable. But if you look at the last plot at the bottom right, this is for like relaxed lockdown by 100%. So we are relaxing the total lockdown, and basically you will see that the red line, the growth of the red line is kind of exponential compared to the blue line. So if you, I mean, you can see even with like a minimal amount of lockdown, we can kind of flatten this exponential growth, where the bottom left line, where we are relaxing lockdown by 50%, you see the growth is not that high compared to the bottom right plot. So even in terms of like isolation, you will see that if we don't isolate any cases, the line, I mean, the trend goes high really fast. But even with just 25% isolation, we can improve the situation by a lot. We can, in our next slide, we will show the amount of improvement we get under these different types of intervention. Next slide, yeah. So here we show the percent reduction. So if you, here we have different, the stages of the intervention we have is 0%, 25%, 50%, 75%, and 100%. And the top left corner, which is marked by red cell, it shows if we don't do anything, basically we cannot improve the overall pandemic situation. So basically that's why the amount of reduction will be 0%. But if you look at the bottom right corner, where we are imposing 100% lockdown and 100% isolation coverage, we can improve the situation by 86%. We can reduce 86% infection transmission. So why is it on 100%? Because in COVID-19, we have asymptomatic cases. So in asymptomatic cases, since they are not showing any sort of symptoms and signs, so they will not get tested. And basically, as a result, we will always have some like infection going on underneath, which won't get detected. So that 13 to 14% reduction we cannot get due to the asymptomatic cases. The next slide. Yeah. So here again, I'm I want to show the cumulative, the trend of cumulative infection forecast till July 31st. So you see, I mean, it's also true for isolation, but you can see, let's say in our country, everyone is kind of complaining that, okay, people are not obeying the lockdown, that lockdown doesn't matter. But let's say even if there is like 25% lockdown, people obeys 25% lockdown, we can cut down around half of the infection, which is a really good improvement. So, I mean, any effort we do, it's doing something. It's not like that nothing's happening. So we should try to, I mean, impose lockdown. If there is no lockdown, we should try to stay home as much as possible, so that we can reduce the amount of transmission. Even if we can reduce the transmission by 10% or 20%, it's a lot. And if you, again here, I'm not showing any numbers due to the non-disclosure agreement, but this is the trend we are showing here. Yeah. And can you go to the next slide? Yeah. So what will be the next target for next steps for this modeling for COVID-19? So we should, this was done for Dhaka, Dhaka city. So we want to expand it for all 64 districts. Though we already, I mean, we have model for different few other districts like Chittagong and Narayanganj, where the disease was spreading pretty fast. But we want to expand it for all 64 districts, if possible, also for Upazila or Thana level. And we also want to forecast for different groups like rural versus urban, different level of income or profession. This is important because we, you will see the most of the infections or like fatality, is it happening in like poor people, or is it somehow distributed to different income level? So this observation is really necessary. Otherwise, the important decision might not be possible to make. And we are also working on forecasting forecasting on emergency resources, such as the projected hospital beds when we will run out of the hospital beds, ICUs, and ventilators. And the immediate next step that we are currently working on, since the government was thinking about zone-wise lockdown, so we are working on zone-wise ABM modeling. And for our economy, garment sector is one of the most important sector. So we are also working on modeling how it will impact for if we can isolate the garments worker, or if we can provide some sort of special policy to our policymakers. So yeah, that was that was all that I wanted to discuss. Thanks a lot. And I think we have some questions about the ABM. So
Yeah, thank you, Jafar Ahmed, for explaining the COVID-19 ABM. So before we go to the Q&A, I know we have the Jumma pair in a few minutes. I want to re-emphasize one very important point that Jafar mentioned, and actually this came in one of the earliest meetings we had as a team, is that whatever numbers we are projecting, whatever forecast or impacts we are showing, we want all these to be proven wrong by the correct and appropriate and timely steps taken by our policymakers. And that could include the Ministry of Health, the ICT Ministry, and all other divisions. So if they can concert their effort together and take the timely action, then we can prove these numbers wrong. And nobody will be more happier than us if this can be proven wrong and we do not have much cases or deaths due to COVID-19. So with that, we conclude the formal presentation and we go to the Q&A section if there is any.
yeah, so can we please go to the slide for ABM, like the 4 plots? Yeah. So the first question was if the scaling of y-axis is same. No, it's not same. So it varies by a lot, but even we had to remove the real cases, the reported cases, because from the reported cases, it's easy to guess what are the scale. So the scales of this 4 plot is not same in y-axis, but for x-axis, it's same. That was the first question.
Okay,
And
Zafar, just give me a minute so that we can try to moderate the questions. Thank you so much for the presentation, Dr. Arifin, Mr. Zafar. It was a great presentation, so we will have about 10 to 15 minutes for questions. I know Johor prayer in a lot of masjids are at 1:15, so people may be leaving for prayers. So we'll have about 10 to 15 minutes of Q&A, and if people want to stick around for further question and discussion, that can happen as well. So the mode for questioning could be, you can either write your question and then I can either read it out for you, or I can ask you to unmute and do the question, or the other option would be to raise your hand. I will look at both. So if you raise your hand, I will go from the list of Zoom raised hands and ask you to unmute and ask your question. So with that, let me first address some of the questions that were already in the chat window, as Mr. Zafar was already doing. So the question he has already answered is, there was a question by Rabi Ibrat. Do the 4 graphs in the previous slide, that is slide 31, have the same scaling? And the answer was already given. The answer is no, it has been anonymized, right? Okay, so the other question is from Salman Shamil. What was the population size in simulation for Dhaka city? So who's going to take that question?
Yeah, the population size of Dhaka city was 13 million.
Okay, so I have next raised hand is Masum Hassan. You want to ask your question? Go ahead and unmute yourself and ask the question.
Thank you, Dr. Saifur. I have a question to Dr. Arifin. My question is, in what I understand from agent-based modeling is we create some agents and we give them some particular characteristics. So suppose if we have malarias and if we have people, we have some characteristics for mosquitoes, and we have some characteristic for people, and we create some agents and we let them do their thing, and finally we try to predict what's the outcome is going to be. So do you think we can do the reverse of this type of modeling? So suppose we have COVID spreading in a particular area. So we know how we know from previous data how it was spreading, how people are dying from this, and we know the outcome and the intermediate steps towards that outcome. And can we model the characteristic of the agents from what we have seen? So is it possible to do the opposite of the agent-based modeling? Is there any sort of work similar to this?
Thank you. I think that's a very interesting question, and I have heard it for the first time in my 12 years of agent-based model talks. So if let me understand it correctly. So you are saying that we have an agent-based model with, let's say, millions of agents in Dhaka city, right? So you want to go reverse. So what is the goal? What do you want to see?
I want to understand the characteristic from the outcome, not the outcome from the characteristic.
Well, in my mind, if I understand you correctly, in my mind that would be more like a machine learning problem, right? Like if I give you the characteristics, like the data from the agent-based model itself, and the goal for what another type of model, or let's say model X, is to learn the reverse characteristics. I don't think agent-based model will be a good candidate for that, but.
Okay.
Who knows, I might be proven wrong. I mean, but this is a very interesting question.
I think I have an interesting answer for this.
Yes.
So sometimes when we have the predictions, and I often ask Zafar, can you tell me which coverage is the current curve is following? And Zafar would tell me like it looks like there is 25% isolation coverage and 50% it's following that particular curve. So I think that's where he's trying to get at.
Mm-hmm. So suppose we take in different type of prevention mechanism, and we have a particular result in a particular city, and in another city we took another set of prevention mechanism and we have another outcome. So based on the outcome and the history that we have, can we understand which one led to a better outcome? So that was what I was trying to ask.
So by which one do you mean the like different interventions, like different coverage levels?
This could be the different interventions, or this could be maybe the characteristic of the people. So in people.
Right. So if that's true, then you are trying to actually understand the impact of the people's characteristics and on top of it, the applied interventions, correct?
Yeah.
So that's exactly what we are doing. It's actually moving. So we are putting the people's characteristics in the model, and we are putting different types of interventions on top of that. Like, for example, 25% in Dhaka, 50% in Gazipur, and we want to see what happens in a few weeks.
So to add to that answer, like, so let's say if we just add the reported cases in our plots, we can easily see that, okay, even though there was some lockdown in our country, like 100%, but we could know that how much lockdown was actually effective. So it's kind of like you can guess in a reverse way that, okay, even if they're saying, okay, this has been done, that has been done, but how much of that is effective, you can guess from the trend.
Okay, yeah, thank you.
Two more questions. So let me read it out. Another question was any of the vaccination options implemented in real life for meningitis? If yes, is the number of infection decreasing according to the prediction?
Yes.
So
I was, yeah, right. So let me go back to the that particular slide where we have this that table. So the question is, what is that? Any of the vaccination options? Yes. So in real life, as I mentioned, they have already implemented MenAfriVac. They also, in Africa, in sub-Saharan Africa, they also administer PMP vaccine and PMC vaccine in a reactive campaign for the last couple of years. But some of the other programs like Prevention 2, which targets middle-aged people like, let's say, 20 to 29 as a broader age group of 1 to 29 years old, some of them are new. They have not yet implemented that, but they're trying to see the impact of that. So most of these have been implemented if you see at the routine column and the reactive column, but for preventive, they're still working on that.
Okay, so sorry, my microphone was muted. There is another question a little bit earlier from Samuel Hassan. He's also a good friend. Thanks for the presentation. How did you model the mobility of people in Dhaka? What is the spatial resolution of this model?
Samuel, thanks for asking, good friend. So how did we model the mobility? So as I mentioned briefly, we did use the contact matrix for Bangladesh, and this came from a famous paper, which we call the Polymod study, which has data of 152 countries' population contact data according to different age groups. So this was our first approximation. But on top of it, we are also planning to add some data from more rich sources. For example, some of the data from the telecom companies or some of the other mobilization data that we might acquire in the near future.
Okay, so along that line, I actually want to inject a question. So how do you model the asymptomatic cases? Like what proportion of the population are you modeling as asymptomatic, and how are you distributing them across the different regions of the country?
Yes, so here comes the epidemiologist. Aisha, you want to chip in?
So currently we're using a 30% asymptomatic infection, and it varies by age. For example, for kids, majority of them are asymptomatic, but for older people, if you are 50 plus, you are much less likely to be asymptomatic.
So the model actually takes care of it on a age group basis?
Yes.
Right.
Okay.
Saifur, if I may add to Samuel's question, so that the spatial resolution has not yet been decided. So for now, what we have showed is done for the entire Dhaka city. But for example, for other types of special situations like zoning or garment factory modeling, we might need to look more in a more granular fashion, let's say to a ward in Dhaka city and so on.
Okay, so great. The next question is from Nafizi Dizatripto. He's a lecturer of our department. Does this model consider special events in specific times while running the simulation? Example, Eid shopping, traveling to home during Eid or Qurbani, the animal market gathering in the near future?
Yes, not yet, but it is planned. We have plans to do so. For example, we might want to see the population influx out of Dhaka during the Eid, and also those kind of questions like Qurbanir Hat. We haven't done that yet, but we have the basic infrastructure ready, on top of which we can do those kind of specific modeling question analysis. So
I'm going to take the liberty of injecting another related question. So you talk about you are planning these simulations. I would also want to kind of understand, is the policymakers asking for these results from you? This may be a tricky question to answer.
Can I say something? Can you turn off the recording?
I guess so. Rifat, can you turn off the recording?
Everybody be aware.
Just a minute.
Thanks, Asha.
Have you started recording?
Yes, yes.
Okay, so the next question is from Dr. Sohail Rahman. What was the temporal resolution? Do you handle individual actions? If yes, then in what time unit? Or do you only apply some probabilistic transitions between and among the states? If that is the case, then how did you estimate the probabilities?
Very relevant questions from another agent-based modeler. So our temporal resolution was a day, each day. Do we handle individual actions? Yes, we do. Like, for example, I guess you meant infection and death or movement, for some of which we have plans to put the spatial model on top of it to model the human movement. Then do you only apply probabilistic transitions, or if that is the case, then how? Okay, so the answer is yes, but not only. We apply probabilistic transitions, yes, and those estimated probabilities comes from our domain experts, basically in this case, Dr. Aisha, and there are some other sources. So that was it, I will say.
Okay, so Dr. Mahmoud Nazin had a question. Many patients did not or do not report or even disclose the infection, but they buy medicine. Is there a way to address these social issues? Even some died with the symptoms and not reported.
Yes, unfortunately, that is true. So the answer is yes, there is a way to address this, but again, we will need relevant data. For example, how much or how many of the population in, let's say, for a specific age group buy medicine but do not report the test. So we need some kind of data to model this special question. And on top of that, Aisha, do you want to add anything for this particular question of medicine buying?
I think not so much about buying medicine, because in Bangladesh, it's there will be virtually no data source to get that information. But if we think about truth, I think there are two available truths we have in here. One is the number of cases that we have tested by PCR, but there's another good source of truth is how many people are dying. And so right now we have information based on how many people are getting tested, but over time there are places in Bangladesh where we have a surveillance system where every death is accounted. And that will be our ultimate source of truth and way of calibration to say how many cases we actually had at one certain point.
Okay, so there is one question. Hold on. So there is another question here. It's from Ratish. Okay, so Dr. Sohel had another query. How long did it take to run 13 million people simulation, and in what sort of a machine? Like what sort of logistics do you need?
Okay, so basically our model is still, I mean, we can manage it within, let's say 8 or 12 gigabyte of RAM. And we have been doing some of these maybe on the cluster. Jafar can give us some more details. Jafar, are you there?
I'm here. So,
okay.
So for Dhaka city, with 16 gigabytes of RAM and like a traditional server is enough, and it takes just few hours to run for different types of intervention. But for like if you think about running for whole Bangladesh or like 64 districts, then we would definitely need to access some supercomputer. I do have access to some supercomputer, but for I think, but I'm not sure if that would be enough based on my allocation. But
yeah, and I'd like to add one thing is once we are planning to do the 64 districts and have some good funding, we are planning to maybe rent some Amazon AWS servers and so on. And there was the first part of Dr. Sohail Rahman's question. Sohail, probably we should talk offline. So sneezing or coughing, those were not included as individual events. We somehow abstracted those to trigger the contamination. But using masks, yes, that has been considered as a separate intervention, although we haven't shown any result from that in today's presentation.
Okay, just for everybody to understand, the question that Dr. Arifin was responding to is, do you consider the individual events like sneezing and coughing that are known to trigger the contamination and using masks, etc. as interventions? Okay, so the next question is from Ratish, Mr. Ratish. How do you compare the success of COVID modeling with the malaria modeling? In which aspects these two modelings are different besides the obvious differences?
Okay, so that's a very good question. First of all, doing anything with COVID is at the same time very challenging and very risky because people are like, even the experts know so little about it. We are basically learning new things every day, and this has been coming from different countries in the world. Even if you look at within one country, the situation changes drastically within a few days, right? For example, in USA, within the last few days, some of the states had crossed all the thresholds as recorded before. So this is the most, I mean, I would say the hardest challenge of working on COVID-19 versus malaria, because when I worked on malaria or meningitis, we already had 30 or even 60 years of data. Well, for malaria, it's more than 100 years because Ronald Ross invented the malaria epidemiology that was more than 100 years ago. And by this time, we had so many literature of research that where should we look for right data? So this is number one. And how is it how are they different? So this is I would say the major difference, and also how are the other obvious difference. So those are obvious, so I won't comment on that. But I think first of all, the newness of the disease, there is no established literature. Everybody is publishing it. There are so many different models coming up every day from different experts. You don't know whom to trust. You don't know whom to believe. There are people who are claiming to have discovered the vaccine for COVID-19 on Facebook Live. There have been this fake propagation of news and other things on which one of our colleagues has been working in this project. So there are challenges for COVID-19 that are very obvious, very unique in a kind of way, and that makes our modeling job harder than working with some of the other more older diseases.
I mean, especially like if you think about the number of parameters, there are a lot of parameters to optimize, but which parameters you should add, you should not add, that depends on the like research and all these. And these are not still kind of, most of the research is going on. They're just doing some sort of like correlation. They're not even doing causation study. So which one to trust and which one will give you a better approximation? It's kind of a like weird judgment, but I mean at the same time it's very critical.
Okay, so the next one is a comment from Dr. Samuel Hassan. This may be useful. Facebook has been generating movement between tiles since March 2020. You may consider using their data for modeling movement. And he has given a link. You can pick up the link from the chat box. Okay, so
yes.
Okay, so I actually have a question. If you go back to slide 31.
Okay, but thank you, Samuel, for sharing this. We will surely look at that. Okay, how do I? Okay, slide 31.
Yeah, that one had a
is,
number. The 31 number was on the slide.
Oh, okay. This one, I guess, right?
No, the one with the 4 graphs, which didn't have the y-axis. Yeah, okay. So why doesn't the blue graph go down on either of these? Like it has 100% isolation and 100% lockdown. If you go to the top left one, it's complete lockdown, complete isolation. Why doesn't the blue curve go down?
Yes, I think Jafar already said about it, but I would let him answer. So these are due to the asymptomatic cases. Jafar, would you explain?
Yeah, so basically, I mean, even though you have like full isolation and complete lockdown, but there are asymptomatic cases which doesn't show any symptoms and signs. So you are like, they are not getting tested using PCR or anything. So they will anyway transmit the disease. So that's why you will see that even with full lockdown and full isolation, maybe the disease will be under control. You can manage, like New York is now doing. Every day they are having 400, 500 cases, so it's manageable. But the epidemic is still going on.
Okay, so I will make a follow-up question between the curves on the diagonal, like the top left and the bottom right. Okay, so in every cases, actually the blue curve is pretty much flat, and you said you anonymized the y-axis so that they don't scale. They're not in the same scale. But I'm just wondering, the blue curve, is it better in the relaxed lockdown by 100%, but 100% isolation coverage compared to the 100% isolation coverage? Compared to the compared to lesser isolation but full lockdown. So, I guess the point I'm making is, would it give better results if there was no lockdown, but we were able to trace most of the individuals who are infected and isolated them?
So actually, if we go to the next slide, we have that percent reduction. So here, if you see that, okay.
Right.
Yeah. So with 100% lockdown, if you see, there are different types, different stages of isolation. So let's say if we can isolate like 100% cases, but there is no lockdown, so we'll see that this is 77% of reduction. But with full lockdown, 0% isolation, it's kind of like 71%. So with isolation, we get more reduction.
Right.
I
And
also
sure.
I was going to explain that with lockdown, lockdown is not test dependent, but isolation is test dependent. So if we want to isolate, we need to test enough to know who has the infection. And on top of asymptomatic infection, we also have a pre-symptomatic infection, which people don't go to get tested until they develop the infection, and then there is a delay from testing to getting the test reports. All of that need to be accounted in isolation.
Okay, so there are some more questions in the chat box. Okay, so all right, so also we're not sure whether we are testing enough, right? Okay, so I guess we have to answer. Like, I guess this is a question for you, like, but I guess kind of obvious answer. We are not testing enough, right? Like,
yes,
we should be doing more testing. Okay, so
Asha, you want to chime in?
I'm like, if you let me talk about that, I can talk for an hour.
No,
we are not testing enough, not even close to enough. Like way less than enough.
Okay. So okay. So the next question is, you must have done some sort of validation against the confirmed cases, I guess. In that case, did you consider the lack of test issue?
So the answer is yes, we did. We have two different type of calibrated results. One is with the current set of under testing, and the other is with the set of enough testing, like what we should call enough, or what we should perceive as enough. So the answer is yes, and I will explain to MSR later.
Okay, so let me see if anybody has raised their hands. I don't see any raised hands, and I don't see any more questions in the chat box. So if anybody have any other questions, this is the time to ask that question, because we are almost wrapping up.
So I think we can also give our email address. You can also like send emails if you have any specific question.
Yeah, okay. So that will be great if you provide all of your, Arifin, if you provide all of your email addresses to me later on, or you can give it in the chat box, that's fine too.
Of course.
Okay, with that, I would like to thank all the speakers and all the people who have collaborated in this project, and thank you so much for your very lively presentation. And I think like the Q&A was very useful for all the people who are concerned in Bangladesh about themselves, their families. They have some real data from some scientists. I think that's great for them to plan their works accordingly. Even though the lockdown is up, the recommendation has always been, if you can stay home, stay home. So we should try to abide by those recommendations, and also follow the rules and regulations for health related matters. Okay, so Rifat, do you want to say anything about what is coming next week? What is our next talk, so that people who have joined in know that there is a talk next week as well?
Yeah, so next week we have a talk about robotics.
Okay. Are we going to, so the question from Mr. Kamrul is, are we going to host a recording somewhere? I guess we haven't decided on that yet, but if we do, we will let you know, right, Rifat?
Yeah, but so I will definitely post the link to our CSC Buet group, and from there, if anyone is not in that group, then maybe Arifin Bhai can share the link, or
okay.
আমার মনে হয় we can post in CSC Buet group, and if that would be enough, right?
I will just give the link. I will host somewhere and just give the link there, so anyone can share the link and see the video.
আচ্ছা, নেক্সট টকটা নিয়ে একটু মোর ডিটেল। এটা হচ্ছে জুলাই 16 থার্সডেতে বাংলাদেশ সময় 8 PM। টাইটেল হচ্ছে টুয়ার্ড ফ্লুয়েন্ট কোলাবোরেশন ইন হিউম্যান রোবট সিস্টেমস, আর স্পিকার হচ্ছে তারিক ইকবাল ফ্রম দ্য ইউনিভার্সিটি অফ ভার্জিনিয়া।
Okay.
So before we conclude, may I just have a concluding remark?
Yes, yes.
So on behalf of my team, of course, we have Jafar, Aisha, and Ruhul Amin. We would like to thank you, the organizers, and I am particularly proud and happy because this is my alma mater and my department. So I would like to thank Rifat, Atif, and Mahmoudan Azdin Madam and Ashik Sir, and last but not least, my dear friend Saifur, who, by the way, has become a tremendously good anchor and like what we call in Bangla, the Shonchalok. So I see a bright future for him as that. Thank you. Thanks from the core of our hearts for giving us the opportunity to give us the talk here.
We are also very proud of the team and of course Arifin, and keep in touch.
Of course we will, madam. Of course. Pleasure.
There is someone else we also need to mention here. Is Auntie listening to the presentation, Arif?
I think she is.
Yeah, she must be very proud.
Parveen, are you there? I think she's on mute.
Talk. No, yeah, she can talk.
Okay. And we hope and pray there will be the end of this pandemic
very soon.
All right. With that, I'd like to thank Arifin, Dr. Niaz Arifin, Jafar, Mr. Jafar, Dr. Aisha, Dr. Ulamin for presenting this talk, and we will conclude this session. Thank you so much. Assalamu alaikum. Stay safe.
Thank you.
Thank you.
Thank you. Allah Hafiz.
Thank you.